To sustain life, the circulatory system has to deliver oxygen as well as nutrients to the tissues and remove all the waste. And the rate at which they do that has to keep pace with tissue metabolism. Thus, it's crucial for the cardiovascular system to respond promptly to the local needs and ensure that the tissues have adequate blood supply at all times to both deliver nutrients and remove wastes. Blood supply to a tissue can be expressed in two terms, both flow and perfusion. Blood flow is the amount of blood that flows through a particular organ, tissue, or blood vessel at any given time. It's measured in milliliters per minute. And perfusion is the flow per given volume of mass of a tissue. That's measured in milliliters per minute per gram. At rest, the total flow is fairly consistent and equal to cardiac output, about 5.25 liters per minute. However, blood flow through individual organs varies from minute to minute, depending on what supply is needed. For example, during digestion, the intestines are going to receive quite a lot of blood flow. However, the kidneys would be shut down. Once digestion's finished, the kidney supply will then be opened up. So, as you can see, there's varied blood flow to individual tissues during any given time. Hemodynamics is the principle of blood flow that's based on this pressure and resistance. Flow is thus proportional to a change in pressure divided by whatever resistance is there. The greater the pressure difference, then the greater the flow, and the greater resistance, the less the flow. These are the principles that we'll use to understand this upcoming material. Blood pressure is the force that blood exerts against the vessel wall. It's often measured in the brachial artery of the arm using a sphygmomanometer. Pressures are recorded as systolic pressure and diastolic pressure. Systolic pressure is the peak arterial blood pressure that's taken during ventricular contraction or ventricular systole. The diastolic pressure is the minimum arterial blood pressure, and that's taken during ventricular relaxation, diastole, between the heartbeats. The normal value for blood pressure for an adult then is 120 millimeters of mercury divided by 75. So 120 in the systolic and 75 diastolic. Pulse pressure is the difference between the systolic and diastolic pressure. This is a very important measure of blood pressure, probably more important than the systolic and diastolic numbers themselves. After all, it's the difference between these two numbers that measures the stress that's exerted on the small arteries during surges of the heart. If there's a huge difference between these numbers, it exhibits that there is little elasticity in the arterial circulation. Mean arterial pressure is the mean pressure that we obtain by taking measurements at several intervals throughout the cardiac cycle. This is sort of what the average pressure is over time. It's equal to the diastolic pressure plus 1/3 of the pulse pressure. That's because we only spend about 1/3 of the cardiac cycle with ventricular contraction. It's this average blood pressure that most influences the risk level for edema or fainting, atherosclerosis, kidney failure, and aneurysm. So hypertension is a condition that results from high blood pressure. It's usually considered to be hypertension when the blood pressure is greater than 140/90 for sustained periods. So transient increases in blood pressure, like that result from exercise or emotional stress, are not hypertension. Hypertension can cause weakening in small arteries and cause aneurysms as well as lead to atherosclerosis. Hypotension is chronic low resting blood pressure. It's often caused by blood loss, dehydration, and anemia, and is also fairly normal in people that are approaching death. One of the body's chief mechanisms for presenting excessive blood pressure is the ability of the arteries to stretch and recoil. It's very important that we maintain this arterial elasticity. As the blood pumps out of the heart, these great vessels will expand, allowing for dampening of the excess blood pressure, and then the recoil maintains a steady flow of blood throughout the cardiac cycle. This smooths out the pressure fluctuations and decreases stress on the small arteries. However, there is still a pulsatile effect in arterial circulation. However, that effect becomes much less pronounced as we move away from the heart. This figure illustrates that. Blood pressure itself lowers the further away that we get from the heart, as well as the difference between these two. And this is really due to the elastic and recoil properties of the vessels. Now, blood pressure in general is going to rise with age. That's because our arteries do, over time, become less distensible, and thus they can absorb less of this systolic force. There are three main factors that will determine our blood pressure. There's cardiac output, the volume of the blood in the system, as well as the peripheral resistance. That is, how much resistance are the vessels providing? If there's a lot of elasticity, then there's less resistance. In addition, the resistance will hinge on the blood's viscosity, the length of the vessel, and the vessel radius. Peripheral resistance is the opposition to flow that blood encounters in vessels that are away from the heart. Without any resistance, there would be no blood pressure. Thus, pressure and resistance are not independent variables, but they both have an impact on the rate of flow. Resistance hinges on these three variables: blood viscosity, vessel length, and vessel diameter. Now, red blood cells and albumin are the primary contributors to blood viscosity. They elevate the viscosity the most if there's excess, and they'll decrease the viscosity if there's a shortage. Sometimes we'll see decreased blood viscosity with anemia, where we have less red blood cells than we should, and in hypoproteinemia, when we've lost a lot of albumin. Sometimes we'll see increased viscosity when we see dehydration. This will slow the flow markedly. Now, vessel length obviously has an impact also. After all, the farther a liquid travels through the tube, the slower it becomes because it encounters more and more friction along the length of each vessel. So pressure as well as flow will decline with distance, as seen in the preceding figure. Now, the vessel radius has the most powerful influence over flow. This is really profound. It's the only real significant way of controlling peripheral resistance, because we can't very well change the length of our vessels, and it would take significant effort to change the viscosity. So vasomotion, or changes in vessel radius, are the best way for us to accomplish influence over the rate of flow. As we already know, vasoconstriction is where the smooth muscle contracts around the vessels. That's from the tunica media. In vasodilation, this muscle layer relaxes and the vessels can become much larger. Now, blood flows in layers as it moves through a vessel, with the layers around the outside experiencing more friction and thus moving more slowly, and layers on the inside moving much faster. Much like if you were to look at a river. In the middle, it's flowing much more rapidly, and at the edges, it experiences much more resistance from the river banks and the base of the river, and thus it flows more slowly. This idea of flowing in layers is called laminar flow. Let's look at how much of a powerful influence the blood vessel diameter can have. So blood flow is proportional actually to the fourth power of radius. So arterioles can constrict usually to about 1/3 of the fully relaxed radius. So let's look at this as an example. If the radius is 1 millimeter, then 1 raised to the fourth power, we're going to see flow of 1 millimeter per second. However, if we change the radius all the way up to 3 millimeters, 3 raised to the fourth power is 81 millimeters per second versus 1 millimeter per second. That's an 81-fold increase in the speed of blood as it travels through a vessel by simply moving from 1 millimeter to 3 millimeter diameter. That's a pretty big impact. So let's spend a moment integrating this information about blood flow. And consider how the velocity of flow differs from one part of the systemic circuit to another. Blood flow in the aorta is fastest because the aorta is the largest vessel, and it decreases as we move towards the capillaries. There are three reasons for this. Remember, there's a greater distance, it's much further, so there's more friction and that reduces speed. Also, we're seeing a smaller radius of each of the arterioles and capillaries, and that offers more resistance, so the blood flow slows. The further from the heart we get, the number of vessels and their total cross-sectional area actually becomes greater and greater. So at this point, it's much larger area for flow than just the aorta itself. And so we actually see, just like rivers flowing into a lake, that the velocity becomes much, much slower. From the capillaries, the blood moves back into the venous supply and ends up in the vena cava. In this portion of the system, flow again increases. We'll see that there's decreased resistance going from the capillaries to the veins, and thus the flow will speed up. There's also a large amount of blood that's being forced into these smaller channels, so that will speed up the flow. However, the venous supply is never going to regain the velocity that we saw in the large arteries because there's simply not the same amount of pressure there due to contraction of the heart. Arterioles are the most significant point of control over peripheral resistance and flow. The arterioles are located on the proximal side of the capillary beds, and they're best positioned to regulate flow into the capillaries. They outnumber any other type of artery, and they provide the most numerous control points. There's more muscle in proportion to their diameter, so they're highly capable of vasomotion, and thus they have a huge impact on the rate of flow. Arterioles produce about half of the total peripheral resistance in the entire body. Take a moment here to close your notes and book and write down all the things that you can remember that influence peripheral resistance. Don't worry how much that you can recall or how much you forget. You can always go back into your notes, cheat, and fill in the gaps. The point here is, again, we're creating curiosity in the brain so that when you come back and review this material, it's there for you. So vasomotion is a very quick way, obviously, to alter blood pressure and flow. There are three ways that we can control the diameter of vessels. First of all, there's local control. There's also neural control, and of course, hormonal control. Autoregulation is the ability of tissues to regulate their own blood supply. There's a metabolic theory of autoregulation. This is where the tissue is inadequately perfused and waste accumulate. Thus, it stimulates vasodilation, which increases perfusion and thus removal. The bloodstream is going to deliver oxygen and remove metabolites. When waste is removed, the vessels will then constrict and things will return to normal. We'll also see vasoactive chemicals that are substances that are secreted locally by the platelets, the endothelial cells, and the perivascular tissue that stimulate vasomotion. These are substances like histamines, bradykinins, prostaglandins. The endothelial cells are capable of secreting their own prostacyclin and nitric oxide, which are vasodilators, as well as endothelins, which are vasoconstrictors. If a tissue's blood supply is cut off from time to time and then restored, it often exhibits something called reactive hyperemia, which is an increase above the normal level of flow. This may be due to the accumulation of metabolites during the period of ischemia. Reactive hyperemia is seen when the skin flushes after a person comes in from the cold. Angiotensins cause the growth of new blood vessels. So hypoxic tissues can increase their own perfusion by secreting angiotensins. We see this often in regrowth of the uterine lining, as well as around the coronary artery obstructions. Physiologists are not quite sure how it's all regulated yet, But we do know that tumors secrete their own growth factors that stimulate a dense network of vessels to grow into them and supply them with blood. If we could block tumor angiotensins, then we could prevent a lot of cancers. So in addition to local control, blood vessels are also under remote control by the central and autonomic nervous systems. The vasomotor center in the medulla oblongata is going to exert sympathetic control over all the blood vessels throughout the body. It stimulates most vessels to constrict and dilates vessels in skeletal and cardiac muscle to meet the demands of exercise. The precapillary sphincters only respond to local hormonal control because they don't have any innervation from the vasomotor center. The vasomotor center is also an integrating center for the three autonomic reflexes that we've looked at previously: baroreceptor reflexes, chemoreceptor reflexes, and then a medullary ischemic reflex that we haven't seen yet. In a baroreflex, we see an automatic negative feedback response to changes in blood pressure. Remember, one set of baroreceptors are up in the carotid arteries. If an increase in blood pressure is detected by these carotid sinuses, signals are sent to the brainstem by the glossopharyngeal nerve. This will inhibit the sympathetic cardiac and vasomotor neurons and thus reduce sympathetic tone. This excites the vagal fibers, slowing the heart rate and the cardiac output, and thus reducing blood pressure. Decreases in blood pressure will have exactly the opposite effect. The baroreflex is very important in short-term regulation of blood pressure. Mainly, they'll take care of adjustments for rapid changes of posture. For example, if you're lying down and then stand up quickly, the baroreflexes will take care of blood pressure very fast so we don't fall down. This figure illustrates the idea of elevated blood pressure and reduced blood pressure and how the neural inputs might work. This could be a good figure to spend a little bit of time with, and make sure you're familiar how this negative pathway works. A chemoreflex is an automatic response to changes in blood chemistry, as we've already investigated. pH, oxygen, and carbon dioxide concentrations are of especial importance. These chemoreceptors are called aortic bodies, remember, located up in the aorta, and carotid bodies that we'll see in the carotid arteries. Their primary role is to adjust rates of respiration in response to changes in blood chemistry. However, one doesn't come without the other, so it has a secondary role in vasomotion. In the event of hypoxemia or hypercapnia or acidosis, the chemoreceptors will be stimulated. They'll act through the vasomotor center and cause widespread vasoconstriction. This will increase blood pressure and increase lung perfusion and gas exchange. Now, the medullary ischemic reflex is an automatic response that results from a drop in perfusion to the brain. So the medulla oblongata, as a backup, monitors its own blood supply, just in case the other mechanisms are not working properly. It'll activate corrective reflexes as soon as it senses ischemia or insufficient perfusion at the medulla itself. The cardiac and vasomotor centers will send sympathetic signals to the heart and blood vessels. This increases heart rate and contraction force that causes widespread vasoconstriction and will raise the blood pressure to restore normal perfusion to the brain. Other brain centers can affect this vasomotor center. This becomes evident when you notice that stress or anger increase your heart rate. So the final component of regulation of blood pressure and flow is the hormonal aspect. Some hormones will regulate through their vasoactive effects, and some by regulating water balance. Angiotensin II is a potent vasoconstrictor. It'll be involved in raising blood pressure. One of the enzymes required for its synthesis is angiotensin converting enzyme, or ACE. Hypertension is often treated with ACE inhibitors, so we prevent the production of angiotensin and thus we prevent raises in blood pressure. Aldosterone is another hormone involved in regulation. It's the salt-retaining hormone. It primarily promotes sodium and water retention by the kidneys, and thus it acts to increase blood volume and blood pressure. Atrial natriuretic peptide is secreted by the heart, and it increases urinary sodium excretion. Thus, it reduces blood volume and promotes vasodilation, which acts to lower blood pressure. Antidiuretic hormone promotes water retention and also raises blood pressure. Its alternate name is vasopressin because in extremely high concentrations, it's also a vasoconstrictor. But both of these effects would raise blood pressure. Finally, there's epinephrine and norepinephrine. They have effects on most blood vessels. They bind to alpha adrenergic receptors and cause vasoconstriction. In skeletal and cardiac muscle blood vessels, they bind to the beta adrenergic receptors and cause vasodilation. And that makes sense because epinephrine is a fight or flight hormone, and if we're fighting or flighting, we need to move away from whatever the hazard is. Thus, we need to activate the skeletal muscles. Vasodilation will help us deliver more blood there. Vasomotion can serve either of two physiological purposes. It can cause a generalized raising or lowering of blood pressure throughout the body, or it could selectively modify perfusion of a particular organ and thus reroute blood from one region of the body to another. A generalized increase in blood pressure requires centralized control and action on the part of the medullary vasomotor control center or by hormones that are in circulation. This is very important in supporting cerebral perfusion during hemorrhage or dehydration. The rerouting of blood is either centrally or locally controlled. During exercise, the sympathetic system will reduce blood flow to the kidneys and digestive tract and increase blood flow to skeletal muscles. On the other hand, dozing in an armchair after a big meal will see vasoconstriction of vessels in the lower limbs, which raises blood pressure above the limbs and thus redirects blood into the intestinal arteries. This figure shows us the rest and digest condition of the blood vessels and then the increased blood flow to the legs in order to accomplish the needs of exercise. These tables give us a great picture of how blood is distributed during exercise and at rest. Certainly, we see much more muscular perfusion during exercise than we do at rest, where we see the digestive and renal and cerebral systems receiving much more blood flow. The adaptability of the circulatory system is just amazing. Spend some time here to outline the influences that regulate blood pressure and flow. Remember, there's local controls, neural controls, and hormonal controls. And we'll see you in the next section, where we'll take a look at the details of capillary exchange.